Case File TR 7734, submitted to the Twilight Registry by a third party on behalf of the primary witness. Primary witness: Dr. Aldous Crane, DDS. Practice location: Harlow, Nebraska. Population: 10112. Status: unresolved. Witness unreachable as of February 14th. The first thing you need to understand is that Dr. Crane was not the kind of man who made mistakes. He had practiced general dentistry in Harlow for 19 years. He had trained at a good school. He kept meticulous records, paper charts cross-indexed with digital imaging, every procedure logged with the date, the tooth number, the depth in millimeters, the material used. His assistant, a woman named Deb Follett, who had worked with him for 11 of those 19 years, told registry investigators that she had never once seen him misidentify a chart, confuse a patient, or reach for the wrong instrument. He was precise. He was careful. He was proud of being those things. Which is why, when he first noticed the cavity in Marian Kessler's lower left second molar, he simply noted it, scheduled her for a filling the following week, and thought nothing more of it. The cavity was unusual only in that it had no visible decay surrounding it. The tooth surface looked healthy, clean enamel. No discoloration, no softening, no plaque gradient that would suggest a slow erosion from acid or sugar. But the cavity was there. A pocket, roughly 2 millimeters wide and 3 millimeters deep, in the mesial pit of tooth number 18. He photographed it. He annotated the chart. He moved on. Marian came back the following week. He prepped the tooth, reached the cavity with his Explorer, a standard dental probe slightly hooked at the tip, and found something that made him stop. The cavity was empty. Not in the ordinary sense. When you excavate decay, you find soft dentin, discolored and crumbling, the biological evidence of damage. What Dr. Crane found when his Explorer entered the pocket was nothing. Clean walls, hard surfaces, no decay whatsoever. He probed deeper, careful not to disturb the surrounding enamel. The cavity was perfectly cylindrical, not the irregular, spreading shape that caries produce. A perfect cylinder, as though bored by a machine. 3 millimeters deep. The bottom was smooth. He filled it anyway. Composite resin, packed carefully, light-cured. Marian left without incident. He didn't mention it to Deb. He wasn't sure what he would have said. The next week, he found the same cavity in Carl Owen's, lower left second molar, tooth number 18. Mesaled pit, 2 millimeters wide, 3 millimeters deep. Clean walls, smooth bottom, no decay. Carl was 44 years old and had never had a cavity in his lower left quadrant before. His chart confirmed it. Dr. Crane sat with his Explorer in his hand for a long moment. He looked at the image on the intraoral camera screen. He looked at Carl's open mouth. He took an X-ray. The X-ray showed nothing abnormal. The pocket didn't appear on the radiograph at all. Not a shadow, not a density change, nothing. The tooth looked pristine from the inside. He filled it. Composite resin. Same protocol. He went home that evening and pulled up his imaging records for the past month. He reviewed every patient he had seen since the second week of January. He found the cavity in 11 of them, Always tooth 18, always the mesial pit, always exactly 2 millimeters wide and 3 millimeters deep, always invisible on X-ray, always clean, no bacteria, no decay, no tissue damage of any kind. No patient had reported any sensation at the site, no sensitivity, no pain, no pressure. They hadn't known it was there. He sat at his desk until nearly midnight. The next morning, he asked Deb to pull the charts for the remaining patients he hadn't reviewed. He worked through lunch, re-examining every imaging file from the previous 6 weeks. When he was done, he had a list of 23 patients, more than 2/3 of everyone he had seen, each with the same finding. He did not fill the remaining cavities that day. He called each patient back, told them there was a minor follow-up procedure, and re-examined them in person. Every one of them still had the cavity, exactly as he had documented it. In the patients he had already filled, the cavity had returned. Same dimensions, clean walls, smooth bottom. The composite resin he had packed into the previous week's fillings was simply gone. He called the Nebraska Dental Association's ethics line that afternoon. He described the situation in clinical terms, carefully, without embellishment. There was a long pause on the other end of the call. The representative asked if he had considered that he might be experiencing instrument calibration issues. Dr. Crane thanked her and ended the call. He ordered a culture kit from a laboratory supply company. When it arrived, he swabbed the cavity in his next patient, a woman named Tessa Wren, 29 years old, healthy, no prior history, and sent the sample in for analysis. The lab called him 4 days later. The swab had returned negative for all bacteria, fungi, and viral markers tested. The sample was, according to the technician, effectively sterile, cleaner than the air in the room. The technician said, with an uncertain laugh, it was Deb who first noticed the movement. She had been assisting on a routine cleaning when Dr. Crane paused to examine the patient's lower left quadrant. He had his mirror and explorer in position, and Deb was watching the intraoral camera feed on the wall monitor. She thought at first that there was a reflection artifact, a shimmer at the bottom of the cavity, a trick of the fiber optic light. She asked him if he saw it too. He was quiet for a moment. Then he said yes. The shimmer was rhythmic, slow, regular as breathing, but not breathing. No biological tissue moves with that kind of symmetry, that kind of deliberate, metronomic pulse. It was visible for approximately 4 seconds before it stopped. Dr. Crane completed the appointment without speaking further about it. That evening, he wrote a 7-page report and emailed it to the Twilight Registry's general submission address. The report was methodical, organized, cross-referenced with patient ID codes rather than names to preserve privacy. He included 14 dental photographs, 4 X-rays, the laboratory culture report, and a 2-second video clip captured from the intraoral camera, slightly blurred due to the magnification limits of the device, but showing, at the bottom of the cavity, a movement that has not been categorized or explained by any consultant the registry has since engaged. His last email to the registry was sent on February 9th. It contained 3 words. It recognized me. The practice has been closed since February 14th. Deb Follett has given 2 statements to registry investigators and 1 to local law enforcement. In both, she describes the last day she saw Dr. Crane clearly and consistently. He came in early. He was calm. He re-examined 4 patients who had morning appointments. After the 4th, He dismissed Deb for the day, told her he needed to run some diagnostics on the imaging equipment alone. She left at 10:30 in the morning. She says he seemed fine. She says he seemed like himself. The practice door was locked from the inside when she returned the following morning. The lights were off. His car was in the lot. There were no signs of disturbance inside. The records were in order. The instruments had been cleaned and re-sterilized and set in their trays. His chair, the dentist's stool at the head of the operatory, had been positioned facing the wall-mounted monitor. The intraoral camera was still plugged in, still active. The last image on its memory card was taken at 11:47 a.m. on February 13th. It shows nothing but darkness, and at the bottom right corner of the frame, a curved surface, smooth and pale, that investigators have been unable to identify as any part of the room's equipment or architecture. It resembles the inside of a tooth. Case TR7734 remains open. The Twilight Registry does not currently have a mechanism for classifying what Dr. Crane documented. We have, however, cross-referenced his patient records against registry databases and identified 23 individuals from 22 other towns across 7 states, none of whom have ever been patients of Dr. Crane, none of whom have ever visited Harlow, Nebraska, who have independently reported the same finding at the same tooth in examinations conducted by their own dentists over the past 11 months. Each was examined in a different city. Each cavity is identical. We do not know what that means. We are noting it because that is what we do.